Cole County 911, location of your emergency.
You have to help him! He looks like he's really hurt!
Ma'am, calm down. Who's hurt?
A boy, he was hit by a car. He's just laying there. There's so much blood. You have to help him!
Ma'am, what's your name?
Tiffany Eggleston.
Tiffany, where are you located?
The accident happened right in front of my house on Rose Lane. He's lying in the middle of the road. Where's the ambulance?
Tiffany, the ambulance is on its way. Are you next to him?
No, I'm still in my house.
Are you able to get next to him?
Yeah, I'm on my way. Oh, are you okay? Okay, I'm here. There's a lot of blood. There's a lot of blood.
Is he awake?
No, his eyes are closed.
Is he breathing?
It's really fast. The car just hit him and left.
Tiffany, is there someone there that can help you?
No, I'm by myself.
Are you out of harm's way?
No, he's laying in the middle of the road. I'm just afraid. I'm afraid to move him. It's okay, buddy. It's okay.
He's only about a minute away.
Where are you? Where are you? Who hits a kid and just leaves? I just don't understand. It's okay. It's okay. It's okay. The ambulance is on their way, buddy. Oh, where are they? Oh, here they come. Over here. Oh, they're coming. They're on their way. Oh, I'm so glad you're here.
Rescue 22 to dispatch.
Oh, there's so much blood.
Rescue 22 to dispatch. Shows arrival on scene. We have a pediatric trauma alert. Please put trauma star on standby. We'll advise further.
I think it's Billy.
Let's make sure he's breathing. Is he conscious?
He's breathing about 40 times a minute.
Did you see what happened?
I heard a crash and I looked out of my window and he was just laying there. I think the car just hit him and left.
You got a for you. Okay. At any time you saw him get hit by the car?
Well, I saw him laying on the ground and I heard a crash.
Okay. Is he breathing? What's his rate?
Breathing about 40 times a
Let me
minute.
check his lung sounds here real quick. Go ahead and bag. Okay, we got breath sounds bilaterally. All right, good. Let's see what else is going on. All right. Do you know him personally?
I've seen him around in the neighborhood. I think his name is Billy.
Okay. As soon as we got this on. His name is Billy?
I think so.
Do you know anything about him as far as any kind of
No, I
medical
just know
history
he's
on him?
I just know he lives in the neighborhood.
Okay.
Or at least I think he does. He hangs around. He rides his bike around.
Okay. Appears that we have some kind of open tip fib fracture. We got some abrasions to the chest. How's that bagging? Are you getting any resistance there?
It's going in.
Okay. I'm going to go ahead and have air transport launched, okay? Rescue 22 to dispatch, please go ahead and launch Trauma Star.
Is he going to be okay?
He's going to be okay. So, do you know his parents?
Well, I've seen
all?
him hang around with some other kids, so I might be able to figure out who his parents are. But no, I don't know his parents.
Okay. We're going to ask you to help us for 1 second. Is that okay? Would you be able to help us?
Yes,
Well, we're
I'll
gonna
do
just
whatever
try to
you want me to do.
What we're going to try to do is we're going to try to get him onto this backboard, stabilize him. Once I get all this clothes off here,
You want me to put these on?
if you'd like. How's your bagging? Is it still okay?
So, okay.
Okay. It looks like he's breathing about 40 times a minute, right? All right. Okay.
Hey, Al, where
Hey, there you are. We have a child that was hit by a motor vehicle, unconscious throughout our assessment.
Okay.
Can you do us a favor? Can you go try to locate the family?
Okay.
Okay?
Okay.
Thanant you.
Do a quick assessment.
All right.
An ID?
Not yet. I was working on it.
Okay.
So you can get the right side, I'll get the left side.
Okay.
Billy, can you open your eyes? Okay. So trachea is midline, no JVD. His chest seems to be stable for the most part. Belly is soft, non-tender. Pelvis is good. Good breath sound. Decreased on the right a little bit, but otherwise good breath sounds. And good breath sounds. Great. So what other information do we have besides his name?
Other than Billy, he was hit by a car. It was a hit and run.
Okay.
And he's been unconscious throughout our assessment.
Okay.
Can I get a broad real quick? And then measurement on him.
That'd be great. Let's go ahead and set up for RSI. Let's do 4 mics per kilo of fentanyl. And
He is a blue on the Broslo, guys.
Blue on the Broslo?
Broslo gives us about 22 kilos.
Okay, great. And then I'm going to go ahead and get this mask on.
Copy that. Once I get this IV established, I'll work on the RSI equipment.
Great. I'm going to go ahead and try to get my gear together, and then I'll take over bagging for you. So, what other injuries besides his chest, his leg?
Haven't been able to get him. Well, we obviously have an open tip fib. As soon as we get him on the board, we can roll him over, and we can check out the back.
Great. Okay. Great. Do we have the pedestrian or the driver of that vehicle?
No, supposedly it was a hit and run. I'm going to apply an air splint to this so we can stabilize at the same time.
Great. We need to kind of get going here.
Yep.
I'm a bit worried. We also need to get him on the monitor if we can instead of vital signs before we go forward with the medication.
You got it.
Okay, IV's in. It's painting.
Great.
Got the KBO. I'm going to prepare the RSI.
How's he doing on the airways? Are you getting any resistance? Okay.
Where's your monitor stuff? Is it on the stretcher?
Right on the stretcher.
Yep. Okay. I can get that for you.
You can also get the backboard.
All right. Good deal.
Pass me the cable, then I'll connect them.
Okay. We got pulses on the
Cable's
distal
coming.
end here.
Okay, I got the Broslo in place. Looks like he's a blue, 22 kilograms.
22, you said?
22 kilograms.
So Untitled CO2's already set up and ready to go. All right. So what do we do? What's left?
You want me to get a blood pressure real quick?
Yes, please, and a pulse ox.
Okay.
Preparing the lidocaine for the head injury.
All right.
0.5 milligrams per
Why don't you
kilogram.
go ahead and get him in hand. I'm going to start bagging for you, so I'll switch with you. Billy, can you open your eyes? So, 5-year-old male, unknown history, unknown meds, unknown allergies. Reportedly a pedestrian or a bicyclist struck.
Yep.
We have his
That's already
helmet, right?
inflated.
Is there any
already
damage
inflated.
to that helmet at all?
No damage to the helmet.
Okay, good deal. We have family going, somebody going to get family or trying to find
Yeah, the
family
lady
members.
that we had was trying to find her.
So, heart rate about 140. Looks like sinus tach on the monitor. Air split's in place. C-spine is taken care of. About the only thing that remains is the RSI meds once we get, what was the blood pressure?
Copy
90
that.
over 40.
90 over 40.
Preparing RSI meds.
Great. So 4 mics per kilo of fentanyl. We're going to do 0.5 milligrams per kilo of lidocaine and 1 milligram per kilo of rocuronium.
Okay,
Billy, we're
we'll
just helping you breathe.
Gotta get going, right?
Yeah, we got to get going.
Okay, these meds are being prepared.
Great. So he has 2 IVs in place, good blood pressure, collar
Yeah.
in place. We know his weight is 22 kilos.
Read on your airway.
I'm good to go. As soon as he gets ready to draw, I'm going to need you to bag for
I
him.
have the lidocaine prepared. I have the fentanyl prepared, 88 micrograms.
Yeah, that sounds good.
And drawing up the rock, 1 milligram per kilogram.
Pulse ox is, we get that? Yeah, pulse ox comes back as 98.
98 of pulse ox, okay.
So let's do fentanyl for, let's do lidocaine first, and then fentanyl, and then rock.
Yeah, I got a
Okay,
second
so
line over here.
I'm sorry?
Lidocaine, fentanyl, then
Yeah,
rock.
we're going to backboard him. Let's
I got a second line
go
here.
ahead and get him intubated, and then we'll throw him on the board.
You want this running KBO? Or you want to?
Keep bagging. Sorry,
Keep
yeah.
it KBO for right now?
KBO.
Okay. Got sharps taken care of.
Thank you.
We got
Ours as
Untitled
well.
CO2.
Okay, RSI is, RSI medications are prepared and drawn.
Okay, so let's go ahead and give the lidocaine. Oh, suction is ready here.
Okay, we're preparing to administer lidocaine. Be 11 milligrams, 0.5 milligram per kilogram.
Pulse ox is 94.
90. Okay, so it's dropping, so we need to get going. Are we all ready for the backboard and everything as well?
I'm ready.
Okay.
Just waiting. Awesome.
Pinching my line. We have 11 milligrams lidocaine on board.
Okay.
Flushing.
All right, so let's go ahead and go with the fentanyl. We're going to bag them, give that 30 seconds to wait, and then we'll go ahead and go with the rock.
Okay, you ready for the fentanyl?
Go ahead.
88 micrograms of fentanyl. Go slow IV push.
I'm going to listen again to those lung sounds.
That'd be great. If we can get another blood pressure while he's giving that fentanyl, that'd be awesome.
You got it.
His pulse ox doesn't seem like it's changed at all. It's still at 94.
Pulse ox remains the same.
Administering fentanyl.
He's still running hot, so we're going to have to get going.
We got 86 over 36.
Okay. Yeah. Well, let's get him on the board and we'll get him covered up.
Okay.
So,
Watch your knee there.
All right, guys.
Are you ready?
hold on one second. Let's get him. Let me get him intubated, or let him finish the fentanyl. Let's put him on the board, and then let me get him intubated.
We're gonna pat him on the board. We got good alignment.
Okay, fentanyl's on board.
All right, so go ahead and put him on the board.
Let me know when you're ready. One, two, three.
3.
Look at the back real quick. Nothing posterior. Let's see what clip it is.
Back's clear?
Yep.
All right. Go ahead with the rock.
Okay, going with the rock. Are you ready?
Yeah.
22 milligrams, rock.
Go ahead and bag him and I'll take care of this.
Okay, we're gonna need a covering.
Yeah,
so
we'll get him covered. Absolutely.
Pinch my line.
I'm gonna secure his
Okay.
arm here. Okay,
that's fine.
Looks like he's starting to stop breathing.
Okay. Rock on board, 22 milligrams.
Switch.
Flushing.
Oscar, get me the O2 tank out of there. I'm gonna secure it over here.
You
want to give me that?
Cool. Listening over the epigastrium. I have no epigastric sounds. Left base. I have breath sounds present. Right base sounds. Lung sounds present.
Great. It looks like
your end-tidal CO2 is 35.
Breath sounds are present.
Are we ready to go?
I need one more blood pressure if I can because of the medication, and then we're ready to go.
Okay. I'll get those stretcher.
What's his pulse ox? I need just a quick piece of tape if I can to secure this tube.
Okay. Let me get some tape.
We're ready to go.
All right. I'm holding the tube. Go ahead.
80 over 38.
80 over 38. Heart rate still looks like it's about 150.
Reduce the hypothermia effect. Make sure we secure it so that way it doesn't fly off the helicopter.
Okay, you have the Broswell. Got the IV, the KVO.
Are you ready?
You ready?
Start wrapping up our
You guys
equipment here.
All right.
1, 2, 3.
Got all the gear. If you can grab that helmet for me, that'd be great too. I'm going to need that for the
You need the helmet?
You got the helmet?
Grabbing it.
Okay. Ready to go, sir?
Yeah, absolutely.
Air Mobile 1. Okay, Deacon log is off this time. En route 18 minutes. We currently have 4 personnel on board and 1 hour of fuel. Roger, Air Mobile 1 looking for the house.
ABAM, this is Air Mobile 1.
This is ABAM General Hospital. We copy, over.
Good morning, ABAM. This is Air Mobile 1 inbound to your facility with about less than a 5-minute ETA. On board, I have a 5-year-old male who was struck by a vehicle at an unknown rate of speed. He was wearing a helmet. Patient reported to be unconscious at the scene and remains as such. The injuries on him are his right face, right chest, and left leg, which is splinted at this point. We did have some blood in his airway, which resulted in him being RSI'd and intubated, and so he remains intubated at this point. Unknown history, meds or allergies. Last blood pressure 80/60. Heart rate at this point is 150. Sinus tach on the monitor. Respirations are assisted, and a pulse ox is 99%. He's got a GCS of 3. Any questions?
No questions. We'll see you in 5 minutes.
See you in 5. Thank you.
All right, guys, we have a Pediatric Trauma 1 coming in. We're going to need trauma surgery, orthopedic surgery, neurosurgery. I need blood set up for bilateral chest tubes, bilateral IVs. Let's get ready now. Everyone got their PPEs on? All right, they're here. What's changed?
Remains unconscious. I have not given him any other paralytics outside of the initial RSI drugs. His last set of vital signs are the same, and he's still unconscious. And he does have a 20 on that right arm.
All right, confirm that those lines are working. All right, give me a squeeze. Breath sounds on the left. Breath sounds on the right. We're diminished with crackles. We're probably looking at pulmonary contusion. I need that capnometer. Also, let's make double sure that this is in. All right. We've got a thready radial pulse, a bounding femoral pulse. So he's borderline hypotensive. Let's go ahead and bolus him up.
Doctor, IV is infiltrated.
Use the other IV.
I can't get an IV, and he's hypotensive.
We must have. Give me the intraosseous line. Give me the intraosseous drill. And keep working on those peripherals. Talk to me. What does that mean in kilos?
22 kilos.
All right, intraosseous line is in. I need the lactated Rainers. You said 22 kilos?
22.
Give me 200. Give me 400 cc's of lactated ringer. Bolus through that IO. Put it on a pressure bag. Let's get it in quick. Oh, I need this kid boil.
Blood pressure's 46/20. This kid needs blood.
Scratch the lactated ringers. Get blood and put blood on the pressure bag. Let's get this taken care of. Now. All right. So he's got massive head trauma. Looks like he might be in a coma. Open your eyes. Billy, squeeze my hands. Squeeze my hands. He's not responding. This must be...
Because the rock hasn't worn off yet.
He might be paralyzed. He might be in a coma. I don't know. Let's presume the worst. Presume that he's in a coma from head trauma and just continue on. Looks like the chest wall has crepitus, contusions, ecchymosis. The pelvis is stable. This tibia is trashed. He's got an open tibia and it's a pulseless foot. Actually, both his feet are pulseless. I don't know whether this is hypotension or not. Get the blood in. Infuse more blood. I need another 10 cc's per kilo. Give me 220 cc's of blood. He's got he's losing blood from the scalp left. Take this down. I need a pressure dressing. Give me a stapler.
I don't think that's your priority right now. It's laceration on the head.
I can't have him bleeding to death from a scalp laceration. If you can control it with your hands, do it. But pay attention. I don't want this kid losing any more blood. Infuse it, and let's see his back. We need to roll him and see where this blood is coming from. This hypotension has got to be addressed. I want you to hold inline stabilization. Let's take these head blocks off.
got the tube. I'm holding.
All right. All right, he's got a scalp laceration, which is controlled. The C-spine, there's no step off. His T-spine is normal. The lumbar spine is normal. He has no rectal tone. I don't know whether that's a paralytics or whether he's transected his spinal cord, but let's just assume it is. All right, rolling back.
On my count, 1, 2, 3, roll back. Good.
All right, so we've got primary, secondary survey. He's got blood. He's got fluid. We're looking good. How are we doing? Let's give me another set of vital signs. Yeah, actually keep him warm. We don't want him getting coagulopathic.
I think we're losing him, Doc.
What are you talking about? What? All right.
No pulse, Doc.
Start compressions. I need 0.3 of epi IO. Where is trauma? All right, we got to find this blood. All right. Boot up the ultrasound machine. All right, his liver and kidney look okay. Speed up those compressions. I don't see any blood in Morrison's pouch. The diaphragm looks okay. It must be his spleen. I can't find his spleen. Looks like we're... I can't see anything. There it is. So his spleen, kidney, there's no blood in his no blood in his left chest. No blood in the abdomen. I see cardiogenic shock. I can see his heart. I can barely get in here. So the liver looks fine from here. There's no cardiac tamponade. The heart function is normal. He's got no effusion. The wall motion looks normal. We've bolused him. We've given him epi. We've given him fluid. We've given him blood. He's not.
Maybe it's not blood. Maybe it's something else.
It's trauma. It's blood.
I'm getting a lot of resistance inside.
Hold on. Hold compressions. Give me a squeeze. He's got absent breath sounds. The problem's not blood. It is air. I need a chest tube. I need a number 10 blade. I need the Pleurovac. I need a scalpel. I need it now.
Do you have respiratory down here yet? Where's respiratory at?
All right, I'm opening the chest. This is going to get wet. Hand me this. Keep it sterile.
Watch the line there, Doc. Watch the line.
All right, I'm in. All right, all right, air, fluid. I need a Pleurovac. All right, we're getting blood.
Doc, less resistance on the back.
All right, we're moving air again.
Want another set of vitals?
Yeah, go ahead and repeat those.
Doctor, we do have a pulse. Vital signs 100/50.
All right, so this is undiagnosed pneumothorax. Great job, guys. The simulation's over, and well done.
Thank you. So at this point, we're going to have all of our different scene teams come back up, and we're going to try to do a kind of a shortened version of a debrief to allow you to see what this is all about for us. And so I think the first step is to go around and kind of just introduce ourselves, where we're from, and what role we played in the scenario.
Hi, everybody. My name is Alex Beguer. I'm a firefighter paramedic and also a flight medic with Monroe County Fire Rescue.
My name is Al Bruins. I'm one of the associate directors at the Gordon Center at the University of Miami. I'm also a battalion chief for Monroe County Fire Rescue.
My name is Oscar Rodriguez. I'm a corps instructor with the University of Miami, and I'm also a firefighter paramedic for the city of Margate.
My name is Amar Patel. I'm the director of the Center for Innovative Learning, and I'm also work as a flight paramedic with Wake Med Health and Hospitals.
And I'm Fran Powell, and he's my boss. That's why he passed right over me. I'm a nurse. I'm a simulation education specialist, and I play the bystander.
My name is Phil Santamaria. I'm a firefighter paramedic with the city of Boca Raton for about 20 years. I'm also a sim operator at Palm Beach State College.
My name is Steve Urchid. I'm a fire captain in the city of Margate. I'm also affiliated with the University of Miami.
Dave Marsteiner. I work at City Delray Beach for 20 years, and I'm the lab coordinator for Palm Beach State College.
And I'm Grim Snyder. I'm an emergency physician and the medical director at the Wake Med Center for Innovative Learning.
So do you think that was an impactful scenario? Yeah. I think that was a fantastic scenario. The unique thing about that scenario was that it wasn't one simulation. It was 4, right? Can you count that? The bystander situation, the EMS response, the fire response, the air medical response, and then the hospital response. So it's unique to be able to play 4 different scenes, in theory, all at the same time using one human patient simulator. And that's really important to try to understand. What we're going to try to do is just go around, and each of us, and I'm going to take care of doing the air and the EMS debrief, and Dr. Schneider's going to take care of doing the hospital debrief. And we're going to, and we'll do it out loud, but we're going to talk about what we liked, what we didn't like, what we thought we can improve, and how we can improve our own communication. And I know there are things that I know I did wrong that, thinking through it again, going, I would have done it completely different moving forward. So I'll end it, I guess, and then we'll start with you.
Okay.
I think he has a mic on.
I think it went pretty well. I had my part to do, so I was really focused on what I was doing. I knew that as a flight crew, Amar was going to get the intubation, and I was going to prepare his intubation equipment and get an IV before we did that. So basically, I was just focused in on that, and I was trying to label the meds and get them along, so it was a little bit fumbling there a little bit with the meds. But I tried to echo back the commands, the dosages back. We tried to confirm the dosage, the weight, and the medication as best as possible. Always try to confirm. So I was basically the IV and medication, and I tried to assist with the intubation while everybody else was doing their thing.
Did you feel like it was real? Like, did you feel like you were under stress at the time?
Yeah,
you were going through it?
sure did. Yeah. Absolutely.
So did I, trust me, because I'm going through it and I'm thinking, okay, what if we mess up a dosage? So, our medication dosage for fentanyl is 4 mics per kilo, and I'm thinking to myself, 4 mics times 22 divided by, I'm trying to do math in my head, and it's very difficult in that response to try to do that.
Yeah, usually when we do it is, I try to confirm a few different ways, the medications. One, in my head, but we also have either an app or like a pull-out where we can confirm the dosage on that, and then I'll go with my partner, and we'll try to confirm that, yes, this is the medication and the dose that we want to give at this time for this patient.
As a team, how do you think we did?
I think we did pretty good.
Yeah. And improvements, what do you think we could have improved on?
Improvements, probably just communication and just be a little bit smoother with the medications and stuff like that.
Yeah, cool. Thank you.
Thank you.
So as an initial responder, it's kind of, you got to remember all the steps you got to take when you get on scene, who do you have to notify, and the fact that this is a pediatric really starts getting you a lot more intense, and especially when there's 180 people looking at you, you got to remember all the steps. And so it's kind of like, it was kind of like frustrating for me because I don't know if anybody noticed, I couldn't cut the clothing off. I tried so hard. And that happens in real life. Well, this is a simulation environment, and you're like, we got to move. This kid is a pediatric trauma. And if you notice throughout the scenario, it was kind of like, okay, so I'm going now to the side as a student going through this. I kind of felt like who was really in charge?
Yeah.
Was it me or was it the air crew? Well, I'm thinking the air crew because they're more experienced and they pretty much have all the drugs and everything else. But in reality, it should be the first one on scene is pretty much who runs the show. But I didn't feel that way. And that's something that, as for the debriefing part, we can talk about and go over. The other thing is the on-scene time, especially with pediatric trauma. We all know that it's what? Get going. You don't do any of this on scene. You do it en route. So we kind of did a lot more on scene than we should have. But this is a learning environment, and this is where we talk about it.
Basically, I was tied to the head doing C-spine. I realized we should have probably put him on the backboard a little bit quicker so I could have had some free hands and assisted them walking along and maybe taking care of the bleeding. I also, since we only had 2 people on scene, used my knees to control C-spine, which I know is kind of an error because if I have to reach over for stuff, I'm going to be moving. But realistically, if there's only 2 people there, we're going to try as best we can with what we have. So realism-wise, I tried to make it as real as possible and reflect on what I've basically done in real life the majority of the time, which I know is not 100% right, but it's care for the patient. We need to get them out as fast as possible. Basically, I think we did a great job overall. We got them out in a reasonable amount of time. We took care of all that we could on scene, and then we passed them along to the air crew. So I think we did a great job.
I'm curious,
overall.
was anybody timing us? Just curious of what that time was. Way too long? Yeah. And so, it was funny, and this is for me, it was funny because I got so focused on managing his airway, and you prompted me 3 times to say, we got to get him on the board, we got to get him on the board, we got to get him on the board. And I was so focused on getting him intubated when the reality was we should have gotten him on the board and got him situated, because that would have freed up a lot of extra hands.
You guys should have been here yesterday. We had him on the board like that.
Yeah, very different. Very different. It is the 180 people, and then now we're being streamed live. So, yeah. So I think from my standpoint, I think communication to me was key, and I think that was the key to all the success. We talked out loud. I tried to say the assessments over and over and over again, because one of the things that I've learned is that if I don't say it out loud, I'm going to miss something. That's just the way that I work. And so saying it out loud and being able to do that, I think, was one of the strong points to make sure that we talk to each other. The backboard definitely is an area for improvement in the RSI side of it.
The interesting thing, if I can add, is if we're running this as a simulation, we've actually never worked together at all. So this is the first time we've ever worked together. But with our experiences and we're running a simulation, but running in real life, we were still able to hit all the key components as a team. Even though there was no team leader, we still worked together as a team, and that's, I think, was important.
And this the other piece for us as the 4 of us is air crew would always say we're in charge. The ground crew is always going to say they're in charge. And so we can't win. So you just can't win. So I think overall from the EMS and the air medical side, I say we did a fantastic job.
I say we did too. Thank you very much.
Thank you.
So the pediatrics and pediatric trauma is probably the hardest emotional thing for your average healthcare provider. It hits us because it's bloody. It could happen to any of our kids, any of our friends' kids, and so initially the emotions are so much higher. The way we compensate for that is we shut our emotions down during the case, which is fine. However, what I was doing as the physician, as you probably noticed, is I was shutting down everything. There was no input coming to me from external services except what I was thinking. I saw it. I saw blood. And in trauma, the answer is always hemorrhage, hemorrhage, hemorrhage. Actually, it's not quite always. Sometimes there are other things going on. And there are hints. I got a team. There's information coming in. But because I had to shut down all the emotions, I was shutting down any extra information, which led to a significant delay in care.
I was just a sports specialist on the side, trying to understand what the doctor's saying. These are some of the communication skills that we go through, trying to figure out what he wants, when he wants it, and giving him what he needs. If he was the customer that we were supporting, this is how we would work it. When he needs it, how he needs it, to understand, to help him get that end product. And he did. He finally found it.
Yeah, I'd like to say that I felt like the turning point was we kept communicating, and then he was like, what could it be? What could it be? And then I think I was the one that mentioned maybe it's not blood. and the turning point is when he got the chest tube and he got the air out, and then the patient started coming back. But always, kids are always the most difficult because it always hits home for all of us, but communication was the key.
I also, when we were doing the scenario, I always had the suspicion that it was going to be airway the whole time, but he's much more educated than I am, and I didn't want to step on his toes or anything like that. But yeah, I just think with we could have done a little bit better with more of a systematic approach to the patient to reassess, always go back to the ABCs, and be a little bit more organized. But we all know in emergency room treatment, it's usually not that organized in there, especially when it comes to pediatrics. It's a little bit more chaotic than it is organized. But just being in these stressful situations during a simulation helps us make our treatment better for the real thing. So I think overall it was a good learning experience for us, and I think it went well. Yeah.
We did save a life. That we did. Right? I think overall we did save a life in the grand scheme of things. So, some of the most powerful debriefings are simply posing the question of what about, right? As a facilitator, in reality, as a facilitator, Dr. Snyder or myself wouldn't necessarily be integrally involved in the scenario. We'd be on the sidelines helping to push the scenario along. And we were active participants. And you notice we knew the scenario, and still we had issues, right? And that's important. I think that's really important for us to play along. Would you agree or disagree?
One of my favorite scenario designs, one of the most useful things that you can do in simulation, which you can never do with real patients, is inject a saboteur, inject a mistake, inject a bad leader, and see if the person who's not technically doesn't have the most number of letters after their name will step up and say something is wrong. Stop. Something is wrong. And whether it's an airline crash where the co-pilot notices something's wrong and doesn't want to speak up, or whether it's the paramedic who says, guys, the problem's not air, the problem's not blood, it's air. That kind of impetus, that kind of putting the brakes on the healthcare process to identify a problem is a very powerful thing, something that you can teach relatively easily.
Well, with that, any other comments? No? Well, thank you for your time. Let's give them a round of applause for doing a fantastic job.
Nice job,
Yeah.
That was great. Thank you, guys. It was amazing. I failed to mention in the beginning that maybe most of you saw this, or some of you saw this, that we had a contest for depicting the opening scenario in a sun. And I want to congratulate Tiffany Eggleston, who was the successful winner of submitting a video. Tiffany was in the video. They took the video and then developed a scenario around it. We're going to continue to do that for successive suns. Our next sun is in April in Connecticut. And you can begin submitting your videos relatively soon. Look for that announcement on the Sun website. And Tiffany will have an all-expense trip paid to the next sun as a result of her winning that video. So you can submit your videos and then successively win a chance for the next sun. That concludes the general session for today. Sammy's giving me a waving sign. Okay. All right. I'm sorry. Thank you very much. I'll turn it back over to Amar then. Thank you.
You're welcome. So, I appreciate being the opportunity to talk to you today about developing a successful simulation. The key to a lot of simulation development isn't anything more than taking the time and thinking through it. So it's all about working through the process and understanding the audience that you're educating, and really impactfully developing something that your students can relate to. As I mentioned earlier, my name is Amar Patel. I'm the director for the Center for Innovative Learning. I spent 18 years so far as a paramedic and I'm currently working on my PhD for the Florida folks through Nova Southeastern, right? So I'm right around the corner from my college. For me, it hits home. For me, the PhD relation for me is nothing more than understanding human behavior and human process. It's about developing something that is going to be relation and make an impact moving forward. So whether you're at a school, whether you're at a university, whether you're at a hospital, simulation is simulation. It's all about making a change to that student. As soon as we can get the slides up, I'll... So let me tell you a little bit about the background piece, and I think we're having a technical issue. Is that the dealio? Yeah. Our program was established 4 years ago. We have 23 human patient simulators. We have taught more than 15,000 students in the last 4 years.